Hello. In this video, we'll discuss narcotic or opioid analgesics. We'll learn what they do to the body and a little bit about what the body does to the drug. Remember, that's the pharmacokinetics part. We'll talk a little bit about addiction potential of these drugs and the treatment of addiction. And we'll list some of the most commonly used medications and learn a little bit about their dosing. Opioids bind to receptors in the central nervous system, that's the brain and the spinal cord, producing an altered perception of pain. So just as an FYI, there are three groups of endogenous substances. Endogenous means naturally found in the body with opioid-like action. Those are enkephalins, endorphins, and dynorphins. They possibly function as neurotransmitters, but we don't really know exactly what they do. Most opioids are absorbed very well orally. They can also be absorbed through the lungs, through the nasal or the oral mucosa, and they can also pass through intact skin. After oral administration, some opioids undergo that first pass metabolism in the liver, which reduces their bioavailability. Opioids can be bound to plasma proteins to various degrees, and they're distributed throughout the body. Most opioids are metabolized by the liver and they're excreted through the kidneys. Well, what do opioids do? Well, they relieve pain and they cause sedation. Some people like the way they feel when they're taking a narcotic. They have antitussive action, which means they stop coughing, and that happens by depressing the cough center in the brain. The dose that produces the antitussive effect is much lower than that's required for pain relief. Opioids decrease the propulsive contractions. It's like the GI motility, so you don't have normal GI tract motion, and that can cause constipation. Adverse reactions to opioids. Well, respiratory depression at high doses, that's one that we really worry about because that can kill you. At analgesic doses, opioids can produce nausea and vomiting. Opioids can produce constipation, so it's a good idea if a person's taking an opioid that we suggest maybe a stool softener or a fiber laxative to help them out. Opioids can cause meiosis, and that's contraction of the pupils in the eye. Opioids can increase the smooth muscle tone in the urinary tract and can cause urinary retention. And occasionally, opioids can produce CNS stimulation, which is kind of unusual, so that patient might feel anxiety or restlessness or nervousness. So drug interactions with opioids, well, the one that we're most commonly concerned with is patient gets too sleepy because opioids cause sedation. If they're taking another drug that causes sedation, they get too sleepy. If they get too much of both of those drugs, they could have respiratory depression. And the drugs that we worry about are generally CNS drugs, including alcohol, antidepressants, some antihistamines can cause sleepiness or respiratory depression if given together. Because opioids can stimulate the release of histamine, itching or urticaria, that's hives, can result from their administration. So if a person's allergic to opioids, then we should give them something else. Opioids have not been shown to be teratogenic, but you have to be careful about women that are in labor because it can prolong labor. And it can also depress the baby's ability to breathe if it's given near term. Also, if it's given near term, baby may be born addicted to opioids. They might have respiratory depression, and they might experience withdrawal symptoms. So here's an overview of the meds that we're going to talk about. You're going to be responsible for knowing a little bit more about oxycodone, hydrocodone, codeine, fentanyl, and tramadol because they're more commonly used. So the first specific drug is morphine. It's the prototype of the opioid agonists because it's the first one that was out. It's used parenterally, meaning IV, for postoperative pain in hospitalized patients. It can also be used orally. There are sustained release tablets for patients with severe pain. Another opioid is oxycodone. It's used alone or in combination with either aspirin or acetaminophen. If it's with aspirin, it's Percodan. If it's with acetaminophen, the brand name was Percocet. And it can relieve moderate to severe pain. Combining it with the aspirin or acetaminophen actually improves the analgesic effect because you get some additive or synergistic effects. Hydrocodone was changed from a Schedule 3 to a Schedule 2 starting in October 2014. So some of your books might still say that hydrocodone is a Schedule 3. It's not. Hydrocodone is metabolized to hydromorphone, so it's metabolized to another active substance. Immediate release hydrocodone is only available in the combination product. If it's combined with ibuprofen, it's called Vicoprofen. If it's combined with acetaminophen, brand names were Norco or Loratab or Vicodin. The FDA has reduced the amount of acetaminophen in these combination products to a maximum of 325 milligrams because there was a risk of hepatotoxicity to the toxicity to the liver with too high a dose of acetaminophen. And now there is a hydrocodone extended release product that's available called Zohydro. Another opioid is codeine. Codeine is often mixed with another product like Tylenol or acetaminophen. So that's pretty commonly used, especially in dentistry. So Tylenol number 3 has 30 milligrams of codeine and 300 milligrams of acetaminophen. We're going to talk a little about tramadol. Tramadol, the brand name was Ultram, is a unique analgesic, and it's got kind of an interesting mechanism of action. It has mu opioid agonist action, but it doesn't affect the other 2 receptor sites. It has some properties of an opioid, like codeine and hydrocodone, but its other mechanism involves the inhibition of reuptake of norepinephrine and serotonin. That's similar to how antidepressants work. Its effectiveness in combination with acetaminophen is comparable to codeine or oxycodone with acetaminophen. The adverse reactions include CNS effects like dizziness, sleepiness, could even be stimulation or headache. The GI side effects include nausea, diarrhea, constipation, and vomiting. So there's also package labeling that warns of the possible risk of suicide in patients who have suicidal thoughts or are emotionally disturbed or are prone to addiction. Some other potent narcotics are hydromorphone. The brand name to that is Dilaudid. Methadone is usually used to treat people with addiction problems. Fentanyl patches is the patch that can provide continuous treatment for a patient. Usually it's only for patients who have been on other opioids and they need, the patient needs continuous treatment. So the patches deliver medication over 3 days. So Duragesic patches, that's the brand name for a fentanyl patch, is not for treating a mild or an occasional pain. And there have been deaths due to fatal overdose of fentanyl. 2 major signs of addiction are craving and loss of control of the ability to stop using a drug. So on chronic administration of opioid analgesics, a patient that can lead to a tolerance or a habituation and dependence. Intolerance occurs to all of the effects of the opioids except for meiosis and constipation. That doesn't go away. And overdoses obviously can be deadly. And shoppers, some red flags that you can think about are shoppers might exaggerate pain symptoms or lie about an injury to receive a prescription. They request frequent prescriptions for a drug. They might see 2 or more prescribers for the same problem. They might go to multiple pharmacies. They might travel long distances to see a prescriber. Sometimes they have insurance, but they'll ask the pharmacy to run the prescription for cash because the insurer won't pay for it because it's refilled too soon. Those are all red flags, and a reason for us to get on the prescription monitoring program to get a full picture of what the patient is doing. There's 4 general methods used to treat opioid addiction, and they include substituting an equivalent amount of an opioid, usually it's methadone, for whatever they're injecting. Gradually, the addict is withdrawn from that oral drug. Patient can go cold turkey by withdrawing from the opioid, and they might use some other medications to alleviate the symptoms of withdrawal. We can maintain a patient on methadone. The patient takes a supervised oral dose of methadone on a daily basis. Because the patient develops a tolerance for the effects of the opioid, it stops the patient from getting that rush feeling after injecting a drug like heroin. Administering an orally effective, long-acting antagonist, a drug like naltrexone, Trexan is the brand. It blocks the action of the usual doses of opioids. Naltrexone helps patients overcome opioid addiction by blocking the effects of the opioid drugs, but it has little effect on the opioid craving. A 2011 review of studies suggested that naltrexone, when taken by mouth, was really not superior to placebo. The authors concluded that there was insufficient evidence to support naltrexone therapy when taken by mouth for an opioid use disorder. Oral naltrexone was useful only for a small part of opioid-addicted patients, usually the ones with a stable social situation and a lot of motivation to quit. There are extended-release depot injections of naltrexone. They're administered once per month, and they have proven to be effective in treating opioid abuse. That approach avoids the compliance issues of a patient not skipping their oral doses of naltrexone. The main use of naltrexone is for the treatment of alcoholism. Naltrexone has been shown to decrease heavy drinking and the number of days an alcohol is drunk and the total amount of alcohol consumed. In an overdose situation, the opioid adverse effects can be reversed with naloxone. This antagonist binds to the opioid receptors with a higher affinity than the opioid, but it doesn't activate the receptor. This displaces the opioid, basically knocks them off that receptor site, and it reverses its effects. However, the half-life of naloxone can be shorter than the half-life of the opioid that it's displacing, so a repeat dose may be required. When given IV, it works within about 2 minutes, and when injected into a muscle, it works within about 5 minutes. The medication can also be given in the nose. And the effects of naloxone last about a half an hour to an hour. So if you administer naloxone to an opioid-dependent person, that's going to cause symptoms of opioid withdrawal, including restlessness, agitation, nausea, vomiting, fast heart rate, and sweating. To prevent this, you can give small doses every few minutes until the desired effect is reached, basically the patient starting to wake up. Naloxone appears to be safe in pregnancy and has been given to a limited number of pregnant women. The vials of naloxone are not very expensive. It's about $25 in the US. But the price for a package of 2 of the auto-injectors, which are obviously easier to use, has increased from about $690 back in 2014 to over $4,000 now. So patient instructions, when you're prescribing an opioid, we want them to take it with a full glass of water, take it with food to minimize GI irritation. We tell them to be cautious when they're driving or operating any kind of machinery because this could slow their reaction time. We tell them that it's a good idea to avoid any situation that requires a thought or concentration, again, because their reaction time is slowed and they could be drowsy. These drugs can cause dry mouth and they can cause constipation. Other considerations when you're prescribing an opioid, be aware of prescription abuse. Well, it's a good idea to check that prescription monitoring program. Be aware that these drugs can be worth money on the street, so that the patient isn't reselling them to someone else. If an NSAID would be reasonable to treat pain, that might be a better choice. And generally avoid prescribing large amounts of opiates. If the opiates you feel are necessary, let's make sure you have a good health history and medication history so you know if they're on any other drugs that might have a possible interaction. The other interaction to worry about is over-the-counter agents, especially acetaminophen. So if you're using something like Percocet or Vicodin that has acetaminophen in it and the patient is taking over-the-counter acetaminophen, too much acetaminophen is bad for their liver. Avoid using other sedating drugs, and over-the-counter drugs such as melatonin might have an interaction. And again, just be aware of signs of addiction or abuse. I hope this was helpful, and I will see you all soon.